My name is Sarah Mitchell, and at 34, I've come a long way from my small-town roots. Growing up with nothing prepared me for everything, including owning the very hospital where doctors once judged me as too poor for their elite practice. The irony wasn't lost on me when Dr. Parker at Parkview Medical Associates dismissed me last month, completely unaware that I'd just finalized the purchase of their building. This isn't a revenge story though, it's about creating change through competence rather than spite. Sometimes the best response to prejudice is quiet success and systemic improvement. Before I dive into what happened, where are you watching from today? Drop your location in the comments, hit like and subscribe to see how dignity ultimately triumphs over discrimination in healthcare. I didn't grow up with silver spoons or country club memberships. My childhood home was a modest two-bedroom rental on the outskirts of Millfield, a forgotten manufacturing town where most families lived paycheck to paycheck. My father worked double shifts at the local factory, coming home with hands calloused and clothes smelling of machine oil. My mother cleaned houses for the wealthier families across town, often bringing me along during summer breaks when childcare wasn't an option. "Keep your head down and work hard," Mom would say as we walked up manicured driveways to grand houses. "But never forget you're just as good as anyone else." It was difficult to believe her sometimes, especially when I'd see children my age in those homes surrounded by opportunities one couldn't imagine, private tutors, music lessons, and summer camps that cost more than our monthly rent. They had safety nets I couldn't comprehend. I had parents who worked themselves to exhaustion just to keep our electricity on. My interest in healthcare wasn't born from some childhood dream of becoming a doctor. It came from trauma, watching my grandmother suffer through a terrible experience at our local hospital when I was 13. She had gone in with pneumonia symptoms but was largely ignored in the waiting room for hours. When finally seen, the doctor barely looked at her, dismissing her concerns as just age-related complaints. 3 days later, she was in the ICU fighting for her life. "They didn't listen to her because she's poor," my father had said, his voice tight with anger and helplessness. If she had been wearing pearls instead of a worn cardigan, they'd have treated her differently. That moment crystallized something in me, a determination to someday be in a position where I could ensure that never happened to another family. School became my refuge and my ticket out. While my classmates complained about homework, I saw each assignment as a stepping stone toward something better. The public library became my second home, where I'd study until closing time, often walking home in the dark with a flashlight to save on electricity bills. By 16, I was working 3 part-time jobs, shelving books at the library on weekdays, cashiering at the grocery store on evenings, and babysitting on weekends. Every dollar went into a coffee can labeled college that I kept hidden under a loose floorboard in my closet. Senior year brought both triumph and heartbreak. I graduated as valedictorian, earning a partial scholarship to State University. It covered about half my tuition, a blessing, but not enough. My parents emptied their modest savings account to contribute, but we were still short by thousands. "I'll figure it out," I promised them. "I'll work and take out loans for the rest." College was a culture shock. For the first time, I was surrounded by students who had never worried about money, who complained about budget living while wearing designer clothes and driving cars that cost more than my parents' combined annual income. I worked as a residence hall assistant to cover my housing costs and picked up weekend shifts at a nursing home to pay for books and food. During my junior year, I met someone who would change my life. Dr. Eleanor Reynolds was a guest lecturer in my healthcare economics class. Unlike other professors who seemed distant and theoretical, she spoke about healthcare with passion and practicality. "The American healthcare system is broken," she told us bluntly. "It prioritizes profit over people, paperwork over patients. We need administrators who understand both the human and business sides of medicine." After class, I waited until everyone had left before approaching her. "Dr. Reynolds," I said, my heart racing, "I've been considering medical school, but I'm concerned about the debt. Do you think there are other ways to improve healthcare systems without becoming a physician?" She studied me carefully. "What's your name?" "Sarah Mitchell." "Well, Sarah Mitchell, some of the most important healthcare revolutions are happening in administration and policy, not just in operating rooms. Doctors save lives one patient at a time. Good administrators can save thousands by creating better systems. That conversation shifted my perspective. Medical school had always seemed like the obvious choice for someone interested in healthcare, but the financial reality was daunting. Dr. Reynolds introduced me to the world of healthcare administration, a path where I could potentially make wide-reaching changes. Under her mentorship, I tailored my remaining coursework toward business and healthcare policy. She helped me secure an internship at the hospital where she consulted, giving me my first real glimpse into hospital operations. "You have good instincts," she told me after I'd identified a workflow issue in the billing department that was causing delays in insurance processing. "You see both the forest and the trees, that's rare." When graduation approached, Dr. Reynolds encouraged me to apply for an administrative assistant position at Riverside Community Hospital, a struggling facility serving predominantly low-income patients. "It's not glamorous," she warned, "and the pay is modest. But you'll learn more there in 2 years than you would in 5 at some gleaming corporate hospital." She was right. My first job paid barely enough to cover my small apartment and student loan payments. But what I lacked in salary, I gained in experience. Riverside was understaffed and underfunded, forcing everyone to wear multiple hats. What started as basic administrative duties quickly expanded as I showed aptitude for solving problems. The billing department became my specialty. I noticed patterns in denied claims and developed a system to prevent common errors, increasing the hospital's reimbursement rates by nearly 15% in my first year. That caught the attention of the hospital administrator, who began including me in management meetings despite my junior position. Each day reinforced what my grandmother's experience had taught me, that dignity in healthcare shouldn't be a luxury afforded only to the wealthy. I saw families just like mine struggle with medical bills, choosing between medications and groceries. I witnessed the dedication of staff working with outdated equipment and insufficient resources. And I began to form a vision of what healthcare could be if run with both compassion and business acumen. "You don't need to be wealthy to deserve respect," I would remind our front desk staff during training sessions I eventually led. "Every patient who walks through those doors has inherent dignity, regardless of their insurance status or appearance." My vision was taking shape, but my journey was just beginning. I had no idea then that these early experiences were preparing me for opportunities one couldn't yet imagine, opportunities that would eventually put me in a position to transform not just one hospital, but an entire community's approach to healthcare. My career trajectory changed dramatically during my 3rd year at Riverside Community Hospital. What began as a temporary assignment analyzing department budgets turned into a complete financial audit of the hospital. Working nights and weekends, I compiled a comprehensive report identifying over $2 million in potential savings through operational changes that wouldn't affect patient care. "This is impressive work, Sarah," said James Harrington, the hospital's administrator, sliding my report across his desk. "Most people see numbers. You see opportunities." 2 weeks later, when the hospital's finance manager abruptly resigned, James took a chance on me, a 25-year-old with no formal management experience but a proven track record of results. "The board thinks I'm crazy," he admitted when offering me the position, "but I'd rather have someone with your drive and instincts than someone with a fancy resume who lacks your understanding of our mission." My promotion came with challenges. Several older employees resented reporting to someone they viewed as inexperienced. Department heads pushed back on budget adjustments. Doctors dismissed my suggestions with condescending smiles. "Just wait until she faces her first budget crisis," I overheard one surgeon say. "She'll crumble faster than the cafeteria's mystery meatloaf." Instead of crumbling, I thrived under pressure. When our largest insurance provider threatened to drop our hospital from their network, which would have been financially devastating, I spent 3 days analyzing claims data and found patterns of systematic underpayment on their part. Armed with this evidence, I joined our negotiation team and helped secure not only continued coverage but also retroactive payments for previously underpaid claims. While working full-time, I enrolled in evening MBA classes, specializing in healthcare management. My apartment became a jumble of spreadsheets, textbooks, and takeout containers. Social life was non-existent. I was either at the hospital, in class, or studying. "You're going to burn out," warned James during one of our weekly meetings, noting the dark circles under my eyes. "I'm investing in myself," I replied. "Besides, this doesn't feel like work when you believe in what you're doing." The MBA program connected me with resources beyond our small community hospital. During a healthcare finance symposium, I presented a case study on Riverside's financial turnaround, catching the attention of William Bradford, founder of Bradford Healthcare Investments. "Your approach is refreshing," he said afterward. "Most administrators cut services first when facing financial constraints. You found ways to improve both finances and care quality simultaneously." William became a mentor, occasionally sending me articles or inviting me to conferences where I met others in the healthcare investment world. These connections expanded my perspective beyond day-to-day operations to the broader landscape of healthcare ownership and policy. After completing my MBA with honors, I was promoted to Chief Operating Officer at Riverside. The promotion came with a substantial salary increase, more money than my parents had ever made combined. Yet financial security wasn't my end goal. It was merely a tool for greater impact. When William approached me about a potential opportunity, I was intrigued but skeptical. "Riverside is struggling despite your efforts," he explained over coffee. "The building is outdated, equipment needs replacing, and the community demographics can't support the necessary growth. But what if you could start fresh?" His investment group was considering purchasing Lakeside Memorial, a bankrupt hospital in a neighboring county. They needed someone with both operational expertise and vision to revitalize it. "We'd want you as an equity partner and CEO," he continued. "It's risky, you'd need to invest your own capital alongside ours, but the potential rewards, both financially and in terms of impact, could be substantial." The decision kept me awake for nights. Investing my savings meant risking everything I'd worked for. Leaving Riverside felt like abandoning a mission. Yet the opportunity to build something from the ground up, to create the kind of healthcare facility I'd always envisioned, was too compelling to ignore. I took the leap. The first 6 months at Lakeside tested everything I'd learned. We inherited demoralized staff, outdated systems, and a community deeply skeptical of new ownership. But we also had freedom to innovate that had been impossible within Riverside's established structure. My first priority was changing the culture. We instituted town halls where staff at all levels could voice concerns directly to leadership. We created cross-functional teams to address operational issues. We developed a patient advisory board to ensure community needs were represented in decision-making. Financially, we made strategic investments rather than blanket cuts. The emergency department was modernized first, as it was both the hospital's front door and its biggest revenue generator. We renegotiated vendor contracts, replacing expensive consultants with in-house expertise. We implemented technology to streamline documentation, freeing nurses to spend more time with patients. Within 18 months, Lakeside was operating in the black for the first time in a decade. Patient satisfaction scores rose from the bottom quartile to the top third nationally. Staff turnover dropped by 40%. Our success caught attention. Other struggling hospitals in the region reached out for consultation, which evolved into acquisition opportunities. Bradford Healthcare Investments, impressed with our results, provided capital for expansion. Within 5 years, we had acquired 2 additional facilities, forming Northeast Regional Health System. Each acquisition followed our established playbook: invest in staff, modernize critical infrastructure, streamline operations, and center everything around patient dignity. Each success increased both our financial resources and my ownership stake in the growing system. My personal wealth grew alongside our expansion, though few would have guessed it from my lifestyle. I upgraded from my studio apartment to a modest 3-bedroom house. I replaced my 12-year-old sedan with a newer mid-range model. I started a scholarship fund at my old high school for students interested in healthcare careers. But designer clothes, luxury vacations, and status symbols held little appeal. Success, for me, was measured in systems improved and communities served, not assets acquired. When Bradford Healthcare proposed our most ambitious acquisition yet, purchasing Westside Medical Center, a large urban hospital in financial distress, I relocated to the city to oversee the transition personally. The move meant leaving the familiar community I'd served for years, but it also represented an opportunity to bring our patient-centered approach to an urban environment where disparities in care were even more pronounced. Little did I know that this move would lead to a personal encounter that would test both my professional principles and my personal resolve. 3 months after moving to the city to oversee the Westside Medical Center acquisition, I developed an irritating skin condition on my face and neck. At first, I dismissed it as stress-related. Moving to a new city while managing a major hospital transition would strain anyone's immune system. But when over-the-counter remedies failed to help, I reluctantly acknowledged I needed to see a dermatologist. Finding time for personal medical appointments wasn't easy. Most days began at 5 in the morning with conference calls to our other facilities and ended well after dinner with community meetings or paperwork. Still, the increasingly visible rash was becoming a distraction in meetings, with people constantly asking if I was okay. "You need to take care of yourself too," my assistant Rachel reminded me when I tried to postpone making an appointment yet again. "You're always telling staff that they can't pour from an empty cup." Recognizing the truth in her words, I asked her to find me a reputable dermatologist nearby who could accommodate my schedule. She returned with a recommendation for Parkview Medical Associates, a prestigious practice located just a few blocks from my office. "They have excellent reviews," Rachel said, "and they're affiliated with University Medical Center, which speaks to their credibility. I've scheduled you for Thursday at 4. When I called to confirm my appointment the following day, the receptionist's tone changed noticeably after asking about my insurance. Though I had premium coverage through our hospital network, her questions became increasingly probing. "And what is your occupation?" she asked, a question I'd rarely been asked when scheduling medical appointments. "I work in healthcare administration," I answered simply, not feeling the need to elaborate on my exact position. "I see," she replied, her voice cooling further. "Well, Dr. Parker typically has a 3-month waiting list, but we had a cancellation. You'll need to arrive 15 minutes early to complete paperwork, and we require payment of your copay at the time of service." Thursday afternoon arrived after a particularly grueling morning inspecting the hospital's aging HVAC system. With no time to change, I headed to my appointment in the casual clothes I'd worn for crawling around mechanical rooms: jeans, a plain button-up shirt, and comfortable shoes, my hair pulled back in a simple ponytail. Parkview Medical Associates occupied the entire 18th floor of a gleaming downtown medical building. Stepping off the elevator, I was immediately struck by the opulence: marble floors, original artwork, and a reception area that resembled a luxury hotel lobby more than a medical office. Patients waiting in plush armchairs wore business attire or designer casual wear, many adorned with expensive jewelry and accessories. At the reception desk, a young woman with perfectly styled hair and immaculate makeup looked up at me with a flicker of surprise. "I have an appointment with Dr. Parker," I said. "Sarah Mitchell, 4 o'clock. She glanced at her computer screen, then back at me, her eyes scanning my attire. "Mitchell, yes, I see you here. I'll need your insurance card and ID." I provided both, along with the completed paperwork I'd downloaded and filled out in advance. "There's a $60 copay," she said, her voice slightly louder than necessary. "We accept credit cards or cash." "Credit card is fine," I replied, handing over my card. As she processed the payment, I heard her colleague whisper, "Is that the 4 o'clock? Doesn't look like our usual patient." The first receptionist, whose nameplate read Madison Thompson, shushed her colleague, though not before I caught their exchange. She returned my card along with a clipboard of additional forms. "These need to be completed as well," she said. "And Dr. Parker requires all new patients to sign our financial responsibility form acknowledging that any treatments he recommends may not be fully covered by insurance, and you'll be responsible for the balance." I raised an eyebrow but took the clipboard. "That's unusual." Most practices verify coverage before recommending treatments. Madison's smile tightened. We find it more efficient this way. Dr. Parker's treatments are often specialized. As I completed the forms, I noticed other patients were called back promptly at their appointment times, while I continued to wait well past 4 o'clock. The waiting room gradually emptied until I was the only patient left. The receptionists whispered occasionally, glancing in my direction. At 4:30, a nurse finally called my name. Instead of leading me to an exam room, she directed me to a small office where a man in a white coat sat behind a desk. "Ms. Mitchell, I'm Dr. Parker," he said without standing or offering to shake hands. "Before we proceed with an examination, I wanted to discuss our practice philosophy with you." I nodded, taking the seat across from him. "Parkview Medical Associates caters to a certain clientele," he continued, his tone clinical but with an undercurrent of condescension. "Our patients typically have complex dermatological needs requiring extensive, ongoing treatment protocols. These treatments are often considered premium or elective by insurance companies, meaning substantial out-of-pocket expenses." "I understand," I replied. "But I'd like to at least have an initial consultation to determine what treatment my condition requires." Dr. Parker glanced down at a notation on my chart. "Yes, you're rash. Given what I can see from here, this appears to be a fairly routine inflammatory condition. Nothing that would warrant our specialized approach." He hadn't moved from behind his desk, hadn't examined my skin under proper lighting, hadn't asked a single question about my symptoms or medical history. "In the interest of your time and finances," he continued, already reaching for a prescription pad, "I'm going to refer you to Community Dermatology Clinic. They handle these routine cases quite efficiently, and their fee structure is more accessible." He scribbled something on the pad and extended it across the desk. "They should be able to prescribe a basic corticosteroid cream that should clear this up. Their office is across town, near the General Hospital." I took the referral, momentarily speechless at being dismissed without even a cursory examination. The implication was clear: I didn't belong in his exclusive practice. Whether it was my clothes, my demeanor, or something noted in my paperwork, he had decided I wasn't worth his time. "Thank you for your recommendation," I finally managed, my voice steady despite the humiliation burning in my chest. "I'll consider it." As I stood to leave, Dr. Parker had already turned his attention to his computer, effectively dismissing me. The nurse escorted me back to the reception area, where Madison avoided eye contact as she scheduled the next patient's follow-up appointment. Walking out of the office, I heard her cheerful voice behind me. "Yes, Mrs. Cunningham, Dr. Parker can absolutely see you tomorrow. We always make time for our valued patients." The contrast between her tone with me and with valued patients couldn't have been clearer. The message had been delivered consistently from the moment I'd stepped off the elevator: "You don't belong here. You're not our kind. You're too poor for our practice." As I waited for the elevator, I caught a glimpse of my reflection in the polished doors. Professional, composed, but with a rash that had been deemed unworthy of proper medical attention. In that moment, I wasn't the CEO of a growing hospital network or a successful healthcare executive. I was just another person being judged by appearances and found wanting. The elevator doors opened, and I stepped inside, my mind already shifting from humiliation to determination. This wasn't just about me anymore. It was about every patient who had ever been dismissed, diminished, or denied care based on superficial judgments. And perhaps, though I didn't know it yet, it was about an opportunity to create meaningful change in an unexpected way. The next morning, I pushed the humiliating experience at Parkview Medical Associates to the back of my mind and focused on the mountain of work awaiting me. Our acquisition of Westside Medical Center was entering its final phase, with the legal team sending over stacks of documents requiring my review and signature. There's also the commercial real estate portfolio to go through, my CFO, David Chin, reminded me during our morning briefing. Westside owns several medical office buildings that weren't included in the initial valuation. I nodded, taking the thick folder he handed me. "I'll review these tonight." Hours later, After meetings with department heads and a tour of the ICU renovation site, I finally had a moment to examine the real estate documents. Flipping through property descriptions, tenant lists, and lease agreements, a familiar name suddenly jumped out at me. Parkview Medical Associates. I blinked, sure I was seeing things. But there it was, Dr. Richard Parker's prestigious practice was leasing the entire 18th floor of the Westside Professional Building, a property that would soon be under my ownership. This can't be real, I murmured, scanning the lease details. Not only were they tenants, but their 10-year lease was coming up for renewal in 3 months. According to the notes from Westside's property manager, Parkview was already in preliminary negotiations for renewal terms. A strange feeling washed over me, part vindication, part discomfort. The practice that had deemed me too poor for their services was, in fact, about to become my tenant. The doctor who couldn't be bothered to examine my skin would soon be negotiating with my company for his practice's physical space. For a brief, indulgent moment, I imagined Dr. Parker's face upon learning that the woman he'd dismissed was now his landlord. I pictured raising the rent astronomically or finding reasons to deny the lease renewal altogether. The fantasy was satisfying but fleeting. That's not who you are, I reminded myself aloud. And that's not how you do business. Still, the coincidence was too significant to ignore. I set aside the real estate documents and opened my laptop, searching for more information about Parkview Medical Associates. Their website featured glossy photos of their providers and facilities, along with testimonials from satisfied patients, predominantly executives, celebrities, and other visibly affluent individuals. Their tagline, "Exceptional care for exceptional people," suddenly seemed less like a marketing slogan and more like an explicit statement of exclusivity. Digging deeper, I found reviews across various platforms. While many were positive, praising the practice's expertise and results, there was a troubling pattern among the negative reviews. Multiple patients described experiences similar to mine, being made to feel unwelcome or being referred elsewhere after a cursory meeting, often with comments about better-suited facilities. Several specifically mentioned feeling judged based on their appearance or perceived financial status. One review particularly stood out: after waiting 2 hours past my appointment time, Dr. Parker spent less than 5 minutes with me before deciding my skin condition wasn't interesting enough for his practice. His staff treated me like I was wasting their time because I wasn't wearing designer clothes or driving a luxury car. The pattern was clear and disturbing. Parkview wasn't just an exclusive practice, it appeared to be systematically turning away patients who didn't project wealth or status, often without providing the medical care they sought. The following week, during our scheduled board meeting to discuss the Westside integration, I raised the topic of our dermatology services. Currently, Westside offers limited dermatology coverage through consultations, I explained. I believe we have an opportunity to develop a more comprehensive department that could better serve our patient population. Leonard Blackwell, our board chair, looked interested. What are you envisioning? A full-service dermatology center focusing on both medical and cosmetic services, I replied. Currently, many patients with skin conditions are referred to private practices, which creates continuity of care issues and often results in delays for patients with less generous insurance. Dr. Melissa Watkins, our chief medical officer, nodded in agreement. We've seen similar patterns across specialties. Private practices cherry-pick the well-insured patients, leaving those with Medicaid or high-deductible plans to wait months for hospital-based care. Exactly, I continued. By developing our own department with physicians who are committed to our mission of equitable care, we could ensure all patients receive timely treatment regardless of their coverage or background. The discussion evolved into a broader conversation about specialty services and community needs. As we were wrapping up, Leonard raised an interesting point. Rather than building from scratch, have we considered acquiring existing practices? There might be established dermatology groups looking to join a larger system, which could give us an immediate presence in the market. Several board members voiced support for the idea, noting the potential cost savings and expedited timeline. Sarah, could you have your team look into local practices that might be acquisition candidates? Leonard asked. Particularly any that might already have relationships with Westside. I'll get right on that, I promised, my mind immediately going to Parkview. Over the next few days, I wrestled with my conflicting instincts. Professionally, I knew that approaching Parkview as an acquisition target made business sense. They had an established patient base, experienced physicians, and a prime location in our own building. The synergies were obvious. Personally, however, the thought of working with Dr. Parker and his staff after how they treated me, and apparently many others, was deeply uncomfortable. Would acquiring their practice reward their discriminatory behavior? Or would bringing them under our hospital's inclusive policies create an opportunity for positive change? I discussed the situation with David and our legal counsel, Jessica Rivera, carefully leaving out my personal experience. Parkview has a strong reputation clinically, David noted, reviewing their financials. Their profit margins are impressive, though they've declined slightly in recent years as insurance companies have tightened reimbursements for cosmetic procedures. Jessica added, their lease situation gives us some leverage. Commercial medical space is at a premium downtown, and relocating would be extremely costly for them. What about their practice philosophy? I asked. Do we know if they accept Medicaid patients or those with marketplace insurance plans? David checked his notes. According to our research, their payer mix is heavily skewed toward private insurance and cash pay patients. Less than 5% of their appointments go to Medicare patients, and they don't accept Medicaid at all. That confirmed my suspicions. Parkview wasn't just exclusive by reputation, they had structured their entire business model around serving only the most financially advantageous patients. If we were to acquire them, I said carefully, would we have the authority to adjust their acceptance policies to align with our hospital's mission? Jessica nodded. Absolutely. As the parent organization, we could establish uniform policies across all practices. We'd need to be strategic about implementation to retain their physicians, but yes, we could require acceptance of a broader range of insurance plans. After much consideration, I made my decision. We would approach Parkview Medical Associates about a potential acquisition. Not out of a desire for retribution, but because it represented a genuine opportunity to extend our mission of equitable healthcare to a practice that had lost sight of that fundamental value. The irony wasn't lost on me. The very exclusivity that had led them to dismiss me as a patient might now lead them into my organization. But unlike Dr. Parker, I wouldn't make judgments based on appearances or assumptions. I would approach this as a business decision, guided by our mission and values rather than personal feelings. Set up a meeting with their practice management team, I instructed David. Let's see if they're open to discussion. As he left to make the arrangements, I glanced at the small mirror on my office wall. The skin rash that had prompted my visit to Parkview was finally healing, thanks to a thorough examination and appropriate treatment from a dermatologist at University Hospital. The external irritation was fading, but the internal determination it had sparked was only growing stronger. Preparing for our first meeting with Parkview Medical Associates required thorough research and strategic planning. Our financial team compiled a comprehensive analysis of their practice operations, revenue streams, and market position. The legal department reviewed their existing contracts, potential liabilities, and compliance history. Our medical leadership assessed their clinical outcomes and quality metrics. They're actually in a more vulnerable position than their reputation suggests, David explained during our preparation meeting. Their overhead is extremely high due to their premium location and amenities. Insurance companies are increasingly pushing back on their rates, and their patient volume has plateaued over the past 2 years. Jessica added, their lease renewal is critical for them. Moving would cost upwards of $3 million between build-out, equipment relocation, and lost revenue during transition. Plus, their current location is part of their brand identity. We developed an acquisition offer that was fair but strategic. The proposal included 1. Purchase of the practice at a valuation based on adjusted EBITDA. 2. Employment contracts for all physicians willing to remain. 3. Retention of their brand name and location. 4. Integration with our hospital's electronic medical records and billing systems. 5. Expansion of their insurance participation to include our established payer contracts. The morning of the meeting, I deliberately chose professional but understated attire, a simple navy suit, minimal jewelry, and practical shoes. Nothing that would trigger recognition from my previous visit as a patient, but nothing that screamed wealth or status either. Our team arrived at the Westside administrative offices 15 minutes early. Dr. Parker and his practice administrators were escorted in precisely at 10 o'clock. I recognized him immediately, though his demeanor was completely different from our previous encounter, confident, engaged, ready to talk business. With him were his practice manager, their financial advisor, and 2 other physician partners. "Thank you for joining us," I began, standing to greet them. "I'm Sarah Mitchell, CEO of Northeast Regional Health System, the organization acquiring Westside Medical Center." Dr. Parker shook my hand firmly. "Richard Parker, Managing Partner of Parkview Medical Associates. These are my colleagues, Dr. James Wilson and Dr. Sandra Hayes, along with our practice manager, Melissa Green, and financial advisor, Robert Stein." There was no sign of recognition in his eyes or voice. To him, I was simply another healthcare executive, one worth respecting only because of my current role. It was both validating and somewhat surreal. After introductions, I outlined our interest in their practice. As we expand Westside specialty services, dermatology is a key area for development. Your practice has an excellent clinical reputation and an established presence in the building. We believe there could be significant mutual benefits in bringing Parkview into our network. Dr. Parker nodded, clearly pleased. "We've built Parkview into the premier dermatology practice in the region. Our patients expect a certain level of service and expertise that we've worked hard to deliver." "Can you tell us more about your patient population?" I asked innocently. "We focus on complex dermatological cases," he replied smoothly. "Our patients tend to be discerning individuals who appreciate our thorough approach and premium environment. Many are executives, professionals, and public figures who value both our clinical excellence and our discretion." I nodded. "And your payer mix?" He hesitated slightly. "We're primarily private insurance and direct pay. We find this allows us to provide the level of care our patients expect without the restrictions often imposed by government payers." "I see," I said, maintaining a neutral expression. "And how would you feel about expanding that mix to include a broader range of patients?" Dr. Parker exchanged glances with his colleagues. "We've carefully cultivated our model over 15 years. Any significant changes would need to be approached cautiously to maintain the quality our current patients expect." The conversation continued with detailed discussions of financials, operations, and potential synergies. Throughout the meeting, Dr. Parker and his team emphasized their unique approach and premium positioning repeatedly, code for their selective acceptance policies. When we broke for lunch, David whispered to me, "They're definitely interested. Their questions about valuation and physician compensation suggest they're already thinking about terms." I nodded. "They're also clearly concerned about maintaining their exclusivity. We'll need to address that directly in our formal proposal." Over the next 2 weeks, our teams exchanged information and preliminary terms. As expected, the sticking point was our expectation that they would accept our hospital's insurance contracts and patient acceptance policies. During our second formal meeting, Dr. Parker was direct about his concerns. "Our patients choose us specifically for the experience we provide. The quiet waiting room, unhurried appointments, aesthetic environment, these are only possible because of our current model." "I understand your concern," I replied. "But I believe there's a misconception that accepting diverse insurance plans necessarily means compromising quality or experience. Our proposal includes resources to maintain your facility's standards while expanding access." Dr. Hayes, who had been mostly quiet during previous discussions, spoke up. "Some of us have been advocating for broadening our practice for years. There are many patients with excellent insurance who are turned away because they don't fit a certain profile." The comment clearly made Dr. Parker uncomfortable. We have protocols for appropriate referrals based on clinical needs, not profiles. I seized the opening. Our data suggests that integrating with hospital systems actually enhances practice stability in today's healthcare environment. Insurance pressures will continue regardless, but our size gives U.S. negotiating leverage that independent practices lack. The financial reality was compelling. After 3 more meetings and countless email exchanges, we reached tentative agreement on acquisition terms, including 1. A fair purchase price with an earn-out component tied to patient satisfaction and quality metrics. 2. 5-year physician contracts with competitive compensation packages. 3. Retained autonomy over clinical decisions while adopting system-wide acceptance policies. 4. Phased implementation of insurance expansion to manage transition. 5. Investment in additional providers and extended hours to accommodate increased volume. Throughout the negotiations, Dr. Parker remained unaware of our previous interaction. He treated me with the professional respect accorded to a healthcare executive but showed no recognition of having met me before. His practice manager and other physicians were similarly oblivious. The final agreement was scheduled for signing the following month, after due diligence and formal board approvals. As we concluded what would likely be our last pre-acquisition meeting, Dr. Parker seemed satisfied with the outcome, if still slightly apprehensive about the coming changes. "We've built something special at Parkview," he said as we shook hands. "I trust your organization will respect that legacy." "We absolutely value what you've created," I assured him. "And we look forward to building on that foundation to serve even more patients with the dignity and respect they deserve." As they left our conference room, I caught Dr. Hayes giving me a thoughtful look, as though she sensed there was more to my interest in their practice than purely business considerations. She was right, of course, though not in any way she could have guessed. The following day, our board unanimously approved the acquisition. The irony of the situation wasn't lost on me. The practice that had deemed me unworthy of their care would soon be operating under my leadership, bound by policies that ensured everyone received the same respect regardless of appearance or perceived status. Yet as I signed the final recommendation, I felt no triumph or vindication. This wasn't about settling scores or proving worth. It was about creating a healthcare system where what had happened to me couldn't happen to others. Where dignity wasn't determined by designer clothes or luxury cars but was instead the baseline expectation for every patient who walked through our doors. The day after the acquisition papers were signed, we scheduled an all-staff meeting at Parkview Medical Associates to formally introduce their team to Northeast Regional Health System. Their 18th floor offices had been prepared with welcome packages, new ID badges, and information about our organization's history and mission. I arrived early with our integration team, greeting staff members as they entered the conference room. Many seemed cautiously optimistic about the change, while others appeared apprehensive. The physicians arrived last, with Dr. Parker leading the group, his expression carefully neutral. As the room filled, I noticed Madison Thompson, the receptionist who had been so dismissive during my visit as a patient. She was chatting with colleagues, unaware of who I was beyond my current role as their new CEO. At precisely 9 o'clock, I stepped to the front of the room to begin the presentation. "Good morning, everyone. I'm Sarah Mitchell, CEO of Northeast Regional Health System. Today marks the beginning of an exciting new chapter for both Parkview Medical Associates and our organization." I continued with a brief overview of our hospital network, our mission of providing exceptional care to all patients regardless of background, and our vision for integrating Parkview's expertise into our growing specialty services. While there will be changes in some administrative aspects, what won't change is our commitment to clinical excellence, I assured them. Your skills and dedication are precisely why we sought this partnership. As I spoke, I noticed Madison's expression changing. She was staring at me with growing recognition, her face gradually paling. She leaned over to whisper something to her colleague, who also looked up with widened eyes. Dr. Parker, however, remained oblivious, his attention focused on the presentation slides detailing the transition timeline. It wasn't until I began discussing our patient acceptance policies that his expression shifted to one of slight concern. At Northeast Regional, we believe that every patient deserves to be treated with dignity and respect from the moment they contact our facilities, I emphasized. Our policy is that no patient is turned away based on appearance, background, or insurance status, provided we have the clinical capability to address their needs. As I continued outlining specific policy changes, Madison raised her hand tentatively. Yes? I acknowledged her. Ms. Mitchell, I think we've met before, she said, her voice slightly trembling. The room fell silent. Dr. Parker looked between Madison and me with confusion. Yes, Madison, we have, I confirmed calmly. I was a patient here approximately 2 months ago. I came in with a skin condition and was referred elsewhere after a very brief consultation. Dr. Parker's expression transformed from confusion to shock as recognition finally dawned. You came here as a patient? I did, I replied evenly. I had recently moved to the city to oversee the Westside acquisition. I needed to see a dermatologist and Parkview was recommended for its clinical expertise. The silence in the room was deafening. Several staff members looked uncomfortable, while others seemed confused by the sudden tension. Dr. Parker attempted to recover. We have a specific approach to patient selection based on clinical needs. If there was any misunderstanding? There was no misunderstanding, I interrupted gently but firmly. I was evaluated based on assumptions about my financial status, not my clinical needs. My condition was never properly examined. I turned to address the entire room. I want to be clear. This acquisition was not motivated by that experience. It represents a genuine strategic opportunity for both organizations. However, that experience did highlight exactly why our mission of equitable care is so important. Madison looked down at her hands, clearly mortified. Dr. Hayes and several other staff members appeared troubled but not entirely surprised, suggesting they may have been aware of such practices. I believe in second chances and fresh starts, I continued. That's what today represents. Northeast Regional doesn't expect perfection, we expect growth and commitment to our shared values. Dr. Parker had recovered his composure somewhat. Ms. Mitchell, I want to personally apologize for your experience. That's not how we intend to practice medicine. Intentions and systems don't always align, I replied. Which is why this integration presents an opportunity to examine those systems and ensure they support the excellent clinical care you're capable of providing to all patients who need it. The remainder of the meeting was somewhat tense but productive. We outlined specific changes to patient acceptance protocols, introduced new scheduling software that standardized appointment allocation, and announced training sessions on unconscious bias in healthcare settings. As the meeting concluded, I made a point of speaking directly to the staff. Change can be uncomfortable, but it can also be energizing. I'm not here to vilify anyone or dismiss the quality care you provide. I'm here to ensure that care is accessible to everyone who needs it, regardless of their appearance or background. In the weeks that followed, the integration proceeded with the expected challenges of any acquisition. Some staff members embraced the changes enthusiastically, particularly those who had felt uncomfortable with the previous exclusionary practices. Others required more time and guidance to adjust their perspectives. Dr. Hayes emerged as an unexpected champion for the new policies. I've been arguing for years that we were missing opportunities to treat interesting cases because of our narrow focus on high-net-worth patients, she confided during one implementation meeting. Medicine should be about the condition, not the wallet. Madison approached me after a training session on patient communication. I want you to know I'm truly sorry for how you were treated, she said, her voice sincere. I was taught that our practice had standards, but I never really questioned what those standards were based on. We all absorb the cultures we work in, I told her. What matters is being willing to examine those assumptions when given the opportunity. Dr. Parker proved to be the most resistant to change. While he publicly supported the new policies, his implementation was often reluctant and mechanical. During our monthly review meeting, 3 months after the acquisition, he finally voiced his concerns directly. Our waiting room used to be a calm, exclusive environment, he complained. Now it's crowded with all sorts of people. The whole atmosphere has changed. The atmosphere has become more diverse, I corrected gently. And our patient satisfaction scores have actually improved since the integration. It turns out people appreciate being treated respectfully regardless of their background. But our premium patients still receive excellent care, I finished for him. The difference is that now everyone does. Quality doesn't have to be exclusive to be exceptional. Despite his resistance, our data was compelling. Patient volume had increased by 30%, revenue was up despite lower average per patient charges, and clinical outcomes remained excellent. Several insurance companies had approached us about preferred provider arrangements based on our improved accessibility metrics. Not everyone adapted successfully. 2 months later, Dr. Parker submitted his resignation, citing philosophical differences with the new direction. While I was disappointed we couldn't bring him along on the journey, his departure opened opportunities for physicians who embraced our inclusive approach. I've accepted a position with a private concierge practice, he informed me during his exit interview. I believe that's a better fit for my practice philosophy. I wish you well, Dr. Parker, I replied sincerely. Different models of care have their place in the healthcare ecosystem. As he stood to leave, he hesitated. For what it's worth, I apologize for dismissing you as a patient. It wasn't my finest moment as a physician. Thank you for saying that, I responded. I hope your new position brings you fulfillment. After he left, I reflected on how the acquisition had transformed not just Parkview but also our broader organization. The lessons we'd learned about integrating a practice with a different culture had informed our approach to subsequent acquisitions. The training programs developed for Parkview staff had been expanded across our network, improving patient experiences throughout our system. What had begun as a humiliating personal experience had catalyzed meaningful institutional change, not through retribution or power plays, but through consistent application of our core values. In healthcare, as in life, dignity shouldn't be a luxury available only to some. It should be the foundation upon which all care is built. 6 months after the acquisition, I stood in the newly renovated reception area of what was now called Parkview Dermatology Center at Northeast Regional. The space had been transformed, not to reduce its quality but to improve its accessibility. The intimidating marble and abstract art had been replaced with warm woods and calming nature photography. The reception desk, once elevated like a judge's bench, was now at a welcoming height accessible to patients in wheelchairs. Our patient satisfaction scores are up 14 points since the redesign, noted Dr. Rachel Winters, who had stepped into the role of practice director after Dr. Parker's departure. And our new extended hours have been particularly successful for working patients who couldn't previously take time off during business hours. The changes went far deeper than aesthetics. The practice now accepted all major insurance plans, including Medicaid. We had implemented a sliding scale for uninsured patients and partnered with local community organizations to provide free skin cancer screenings in underserved neighborhoods. Most importantly, every patient was now treated with the same level of respect and attention, regardless of their appearance, background, or financial status. Ms. Gonzalez is here for her follow-up, Madison informed Dr. Winters, her professional demeanor now extending to all patients rather than a select few. She's in room 3 whenever you're ready. Ms. Gonzalez was one of many patients who had been referred away from Parkview under the previous management. With a complex autoimmune condition affecting her skin and limited English proficiency, she had been deemed too complicated for their practice model. Now she was receiving state-of-the-art treatment from specialists who saw her condition as a meaningful clinical challenge rather than an inconvenience. As I observed the daily operations, I was struck by how many of the original staff had not just adapted but thrived under the new approach. Madison had become one of our strongest patient advocates, often going above and beyond to ensure people felt welcome and understood. Several medical assistants who had previously seemed disengaged were now actively participating in quality improvement initiatives. It's like we were all playing a role before, one nurse confided during a staff feedback session. We thought exclusivity meant excellence, but it was exhausting to constantly judge people. Now we can just focus on good medicine. Not every change had been smooth. We'd lost a small percentage of patients who preferred the previous exclusive atmosphere, though they were far outnumbered by new patients eager for quality dermatological care. Some staff members had followed Dr. Parker to his new practice. Each departure had created space for professionals who aligned with our values of accessible excellence. Our work at Parkview had inspired changes throughout our hospital network. We'd implemented standardized training on unconscious bias for all staff, from physicians to environmental services. We'd revised our patient satisfaction surveys to specifically address feelings of dignity and respect. We'd created a patient advisory council with representation from diverse communities to ensure our policies and environment truly served everyone. The impact extended beyond our walls. 3 months earlier, we had launched a mobile dermatology clinic that traveled to rural communities and urban neighborhoods with limited healthcare access. Staffed by Parkview providers on rotation, it brought specialized care to patients who would otherwise go without. The mobile clinic has identified 17 cases of early-stage skin cancer that might have gone undiagnosed, Dr. Winters reported during our monthly review meeting. Several patients have told us they'd been concerned about changes to their skin for years but had no way to see a specialist. One autumn morning, while attending a healthcare leadership conference, I unexpectedly encountered Dr. Parker in the hotel lobby. He looked momentarily uncomfortable but then approached with a polite smile. "Ms. Mitchell, good to see you." "You as well, Dr. Parker. How is your new position?" "Challenging in different ways," he admitted. "The concierge model has its own complications." We chatted briefly about the conference sessions and healthcare trends before he brought up Parkview. "I've heard good things about what you've done with the practice," he said, surprising me. "A colleague mentioned your mobile clinic program specifically." "It's been a rewarding initiative," I replied. "We're reaching patients who have never had access to dermatological care before." He nodded thoughtfully. "I've been reflecting on our previous model. While I still believe there's a place for high-end private practice, I can acknowledge that our approach sometimes excluded patients unnecessarily." "That's a valuable reflection," I said, genuinely appreciative of his candor. "Being on the other side, building a practice from scratch again, has given me perspective on what truly matters in medicine," he continued. "The prestige and exclusivity seem less important now than they once did." Our conversation was brief but meaningful. People rarely change their fundamental beliefs overnight, but experiences can gradually shift perspectives. Dr. Parker might never fully embrace our model of care, but he had at least begun questioning assumptions that once seemed unassailable to him. As I returned to the city, I reflected on my own journey. The humiliation I'd felt in that 18th floor waiting room had been real and painful. But if I'd responded with anger or vengeance, if I'd purchased the practice simply to fire Dr. Parker or publicly shame the staff, nothing meaningful would have changed. One exclusive practice would have closed, and another would have opened elsewhere. The system would have continued unchanged. Instead, by focusing on structural change and creating growth opportunities, we had transformed not just a practice but mindsets. We had demonstrated that excellence and accessibility aren't opposing values but complementary ones. We had created a model that other healthcare organizations were now studying and emulating. My office at Westside Medical Center overlooked the city, including the building where Parkview was located. The view reminded me daily of how far we'd come and how much further we still had to go in creating truly equitable healthcare. The journey wasn't about proving personal worth or exacting revenge. It was about creating systems where every person's inherent dignity was recognized and respected from the moment they sought care. In the end, the most powerful response to discrimination isn't retaliation but reformation, not proving critics wrong but creating something better. Success isn't measured by who you prove yourself to be, but by what you build for others along the way. Have you ever experienced a situation where you were underestimated or judged unfairly? How did you respond? I'd love to hear your stories in the comments below. If this journey resonated with you, Please like and subscribe for more stories about healthcare transformation and personal growth. And if you know someone facing similar challenges, share this video to remind them that sometimes the best revenge isn't revenge at all, it's creating positive change that lifts everyone up. Thank you for joining me today, and remember that your worth is never determined by others' perceptions. It's determined by the impact you choose to make in this world.